A very good day to all the assessor. My name is Win Win. My topic is proteomics and Alzheimer disease. What is proteomics? To know what is proteomics, we have to first know what is proteome. It is a whole collection of proteins synthesized and changed by an organism. So, proteomics is a large-scale analysis study of proteomes. It studies basic structures and functions, interactions, and modifications of protein in the biological system, giving deeper insights into cellular activities than genomics, and it's much more complex than genomics due to its dynamic nature, as there is a constant changing of proteins depending on time and environmental conditions. It is well known that the central dogma of biology is that DNA transcribed into mRNA, and mRNA is translated into amino acid, which is the building blocks of proteins. But question to ask is, does the same amino acid sequence give the same functions in the body? However, the answer is no. Same amino acid sequence does not effectively classify its function, as the same sequence may produce different protein species known as proteoforms, which they exert different biological functions after going through different modifications and interactions. Modification of proteoforms can interrupt physiological functions and result in disease phenotypes, thus making proteoforms and most appropriate indicators of disease state and distinct therapeutic targets. Here, one example is Alzheimer disease. The proteoforms of hyperphosphorylation tau proteins causes the disease. This picture shows the common workflow of proteomics analysis, which begins with samples collection, can be blood, urine, or bodily fluid, followed by protein isolations, whereby protein samples are extracted and loaded into the gel-based or chromatography-based approaches. Then the sample will be further analyzed using mass spectrometer. Then the raw data will be generated from mass spec, will then be further analyzed using bioinformatics to identify proteins' presence in the biospecimens. Statistical analysis will then be carried out to identify biomarkers, followed by validation process. The clinical practice of proteomics include detecting biomarkers for disease diagnosis. MS-based proteomics has been very effective in analyzing proteoforms in biological samples to discover new biomarkers for illnesses. Here state two examples. The lung cancer proteomic profiling subtypes are able to identify protein signatures that help more precise diagnosis and prognosis. And the other one being a combination of proteomics and beta-molomics studies also discover biomarkers to differentiate Alzheimer's disease diagnosis from other forms of dementia. Proteomics has also helped identify therapeutic targets by mapping interaction networks between proteins and functional pathway. For example, proteomic analysis has uncovered novel targets in bladder cancer and also guide drug development. Proteomics also support the new strategies by identifying novel drug targets through understanding the pathology-based mechanism of neurodegenerative disease such as Alzheimer's disease. Advanced proteomic technologies also brought vaccine developments into higher level, as a more detailed information can be obtained through regarding the proteomes of the pathogens provided by proteomic analysis. This reveals identifications of secreted proteins and their virulence-related functions, and hence offer a new avenues for potential vaccines candidates. Now let's go into Alzheimer's disease. It's one of the neurodegenerative disease affecting 46 million individuals worldwide, especially elderly. Its symptoms is progressive memory loss, cognitive regression leading to poor quality of life, and in later stage, it even can't carry out normal activities which require full-time assistance and restlessness, and also lost commands of language and thoughts, which also affect the quality of life of their caretakers. The pathophysiology of AD, although not completely understood, However, there are three established proposed mechanisms. The first one being cholinergic hypothesis, whereby this hypothesis claims that there is a loss of cholinergic activities, which appears the most prominent among other neurotransmitter deficit in AD, and it also correlates with the severity of the disease. In other words, there is a deficiency of acetylcholine, a neurotransmitter in the brain that is involved in memory and learning. The beta amyloid hypothesis believe that AD is caused by an aggregation of abnormally folded beta amyloid proteins. And then these proteins are actually parts of amyloid precursor protein APP after being sliced by two enzymes known as the beta and gamma secretase to produce the isoform amyloid beta 40 and 42. Hence, those isoforms are actually metabolic waste products which were clustered together to form the plaques in AD. And these plaques cause inflammations in brain neurons, interrupting the communication signals between neurons. And there is also a correlation of beta amyloids with the decreased level of acetylcholine, whereby the beta amyloids will negatively influence the cholinergic function and cause a decrease in the acetylcholine level. The third hypothesis claims that there's an abnormal accumulation of tau proteins due to hyperphosphorylation process, which clumps together to form tangles within nerve cells in the brain. In normal brains, tau upholds the microtubule structure and able to deliver nutrients and information throughout the neurons. So when there is a dissociation of the tau, causing the microtubule to collapse and hence disrupt neuron transport system, and there is a malfunction in biochemical signals between neurons. The definitive diagnostic for AD is still through histopathological findings of the amyloid plaques and the tangles of hyperphosphorylated tau. PET, molecular binding imaging scan, and cerebrospinal fluid protein analysis is mainly the diagnostic method to confirm the pathological alterations in AD. Phosphorylated tau 181 in plasma using specialized PET scans ligands have reached accuracy of 96% sensitivity in mild AD, whereas CSF examination of hyperphosphorylated tau, beta amyloid 42, and total tau protein contents has also managed to achieve accuracy of 90%, as there is a reduced CSF beta amyloid 42 and an increased tau isoforms of both the hyperphosphorylated tau and the total tau in AD patients. The ratio of CSF biomarkers, for instance, beta amyloid 42 over 40, has also shown to yield a more precise index of underlying amyloid-associated disease morphology. So both PET scan and CSF analysis can detect pathological changes even before the appearance of AD symptoms, which facilitate early diagnosis of the disease. Traditional FDA-approved pharmacotherapy drugs for AD only alleviate symptoms but do not stop the cause of the disease. One of it being cholinesterase inhibitors. To understand the mechanism, in normal brains, acetylcholine is synthesized via the actions of the enzyme acetyltransferase, and upon arrival of neuronal impulse, acetylcholine is released and binds to the receptors on the postsynaptic neurons. To terminate the transmission, acetylcholine will be hydrolyzed by two enzymes known as the acetylcholinesterase and butyrylcholinesterase. So to stop this enzyme, cholinesterase inhibitors will then lead to the increase of acetylcholine in the synaptic neurons and a longer duration also, so hence to slow down the cognitive decline. The three available cholinesterase inhibitors in the market are donepezil, rivastigmine, and galantamine. This table actually shows the difference and compare between the three drugs. The other types of traditional pharmacotherapeutic choices is known as the NMDA receptor antagonist. NMDA receptor in brain actually plays a crucial role in learning and also produce new memories. Via the transmissions of nerve impulses by glutamate, which is an excitatory neurotransmitter. The accumulation of amyloid beta causes an elevation of glutamate levels by inhibiting the glutamate uptake, which overstimulates the NMDA receptors, leading to too many influxes of calcium, leading to cell rupture. One of the examples of NMDA antagonists is the memantine, which can be combined with cholinesterase inhibitors in patients with moderate to severe AD. Monoclonal antibodies are the newer treatments targeting amyloid plaques in AD by increasing the plaque clearance from the brain. One recently approved in Jan 2023 known as lecanemab shows outcome of 27% slower disease progression in phase 3 trials, and another promising immunotherapy known as the donanemab able to slow down cognitive decline by 35%. Now we'll look into advances in AD. Novel agents targeting beta amyloids are ralitramiprazole, inhibits the beta amyloid oligomers formations and subsequent accumulations. It's already shown positive efficacy in 2/3 of AD patients in phase 2, currently in phase 3 trials, continue to test its efficacy and safety. Another one, CT1812, selectively block the binding of beta amyloid oligomers to neuronal synapse and hence reduces the toxicity effects of beta amyloid oligomers. Also currently under tolerability assessment in phase 2. Third one, APH1105. It's a novel intranasal drug, modulates alpha secretase enzyme, hence decrease the tendency of beta amyloid accumulations, and still undergoing safety and efficacy tests for mild to moderate AD. Another novel agent targets the tau protein. ACI-35030 is a liposome-based vaccine with the addition of second adjuvant and helper T epitopes, stimulates the host immune response by specifically target the pathological tau protein without causing any autoimmune response to the normal functional tau. This drug currently in phase 2 trials assessing its safety and immunogenicity in patients with mild AD. Another humanized IgG1 antibody known as the J&J 637335657 go against the microtubule binding region of tau. It decreased the amount of hyperphosphorylated tau by increased the clearance and stop the spread of p-tau from cell to cell in the brain. There is also a novel cholinergic agent known as memogain. It's an inactive prodrug of galantamine. It's administered intranasally twice daily at 5.5, 11, or 22 milligram. Now still undergoing randomized double-blind trial, and then shows that there is a dose-dependent effect on improving cognition level and is superior over galantamine due to it developed less side effects as it due to the intranasal route, delivering the drug straight away to the brain and not to the systemic. It's being redesigned in another extended release form, tablet form known as the Alpha 1062, currently under bioequivalence study to compare the efficacy with galantamine. Machine learning in phenotyping is also a novel advances in AD, whereby they integrate the ML machine learning algorithm in the analysis of whole-slide imaging in year 2019, and has yielded a precise identifications of tau proteins with score equivalent to semi-quantitative score from expert pathologists. Accurate phenotyping despite the heterogeneity patterns of ADs actually can help speed up more in-depth discovery of AD pathophysiology and advancement in precision medicine. So you see, proteomic analysis have identified numerous proteins that exhibit differential abundance in AD, contributing to the understanding of its pathophysiology. The newer molecular targets of AD treatments are designed based on the knowledge of protein biomarkers affecting onset and progression of AD, and hence finally able to slow down the progression of the disease and cognitive decline in the early course of the disease. With the aid of technology advances, including machine learning algorithms and in vivo biomarkers, greater heights in achieving AD disease understanding are now made possible, paving way for early therapeutic intervention. These are my references, and thank you for your attention.